Thanks for having us back. So we were here, and by here I mean joined your group maybe January of 2021 to kind of do our like pre-conversation with all of you to get you jazzed about the project and to kind of recruit you to be a participant in it. So now we're coming back and sort of saying, here are the conversations that we had, and here's sort of like a summarization of kind of high level what we found. And so I'm Danielle Gartner. So hello, good to see you again. And I'm joined by, I'm an assistant professor in the Department of Epidemiology and Biostatistics at Michigan State University. I am a quantitative person, but dipping toes into the qualitative world because it's so valuable. And I'm also joined by Madeline Nash, and I'll let Madeline give an introduction.
Hi, I'm Madeline Nash. I am a doctoral student in the Department of Sociology. And like Danielle, I'm usually a quantitative person, but I have discovered the joys of in-depth interviews and in-depth, rich data. So it's great to be here. Thank you.
And I should also mention that Heather Howard-Babawash, who's in the anthropology department at MSU, is also part of this project. So any of you who were interviewed or part of this project interviewed with Madeline or Heather while I was away on maternity leave last year. So those two folks might seem familiar to some of you. Yeah, but she couldn't be here. She's teaching during this time. So we're sad to not have her here, but she's here in spirit. So today we're going to cover kind of very high level, I guess. The cool thing about qualitative work is that it dives so deep into concepts and gets into the nuance of stuff. So what we're presenting to you here is not necessarily all of that nuance. It's a little bit more of like this, I guess we could call it like a 5,000-foot view. So we're going to go a little into the deep end and the rabbit holes, but not quite too far. But we're focusing in on kind of, I guess, 6 topics here that are listed, plus the study overview. And just so you know, these topics, when we had our interviews with some of you and with other folks, we included many more topics than this, but for purposes of today and sort of the bulk of what we're reporting on, we focused in on these five topics because both Michelle and Lisa kind of mentioned that these would be kind of important areas to discuss. So we focus in on those. So in terms of the study overview, the objective is that we wanted to consult with perinatal health and well-being experts such as yourself to provide preliminary information about services available to support Michigan's Indigenous women experiencing postpartum depression and anxiety. And then the process that we used, we first started with kind of reviewing the literature and getting a little funding to support a graduate student, such as Madeline in this work. We established a partnership and a kind of a memorandum of understanding with ITC. Then we conducted individual consultations. We analyzed and summarized the information. And then we did a kind of report back to some consultants. And some of you may have been on that call that was in fall, where we said, hey, here's what we heard you say. Is this what you thought you said? And then we created this finalized report, which is part of what we're presenting to you now. So the final products and report include 6 infographics, which you can see at the bottom. And these are intended to be kind of like standalone on the various topics we're presenting today. In addition to these infographics, we have this PowerPoint we're giving you today that kind of coincides with the infographics. And then we also have a longer PowerPoint slide deck that's got the real deep analysis and the like richer information in it. So for those of you who are really into this kind of data, we have that available too. It's got, you know, the real rich and deep stuff. In terms of consultants, we held consultations with 23 professionals who currently are in or with a history of being in relation with perinatal folks. So that included breastfeeding supports, therapists, midwives and doulas, tribal staff, and home visitors. And again, these consultations focused on kind of the 5 areas that I'll be talking about or will be talking about today, which include kind of the causes and consequences of depression and anxiety, screening for postpartum depression, relevant services that are available to address it, what decolonizing services might look like, and then the impact COVID-19 has had on postpartum mental health. So screening for postpartum mental health concerns, we tried to kind of come up with what might be kind of a typical postpartum depression screening experience. And sort of what we said was like around the time of delivery, maybe a little bit earlier, the Edinburgh Postnatal Depression Scale might be used. and to screen for postpartum depression. And that might be used up somewhere between 3 and 9 months or 6 months postpartum. And then the PHQ, or the Patient Health Questionnaire 9, might be used to assess for postpartum depression or other mental health concerns after that. And then if scores from a screener are above sort of this pre-specified cutoff value, then a conversation might happen with a mom to talk about depressive symptoms. But I think given this approach, it's a little difficult to put a number on then the percent of moms that experience postpartum depression. So even when we use the screener, there is likely an underestimate of the true burden. Some moms are going undetected, some are going undiagnosed, and some are gone un or undertreated. And so while we heard many of you say that screeners are really useful tools, but also they don't capture all instances of postpartum depression. And some of the weaknesses of the Edinburgh Postpartum Depression Scale specifically are mentioned here. So one is that moms may not feel comfortable answering the questions truthfully. And we have this quote here that says, because we're mandated reporters, I think a lot of moms get kind of nervous about what they can say and how honest they can be. We also heard that the questions can be worded or structured in a way that doesn't necessarily align with real life experiences of postpartum depression, that some of the content isn't explicit enough regarding suicidality. For example, we have this quote that says, there's one question that says, have you thought about harming yourself? But then I've had the experience with talking with clients where they can interpret that as cutting or other coping mechanisms, which is different from suicidality. There's also the point that given kind of the personal and vulnerable experience of postpartum depression, that just taking a screener can feel inadequate or like a very impersonal tool. And then other postpartum mental health experiences, something like anxiety, bipolar disorder, or many other experiences aren't necessarily considered or screened for using that screener, right? And so we have this quote that says, and then we also do the screeners like the Edinburgh screener. So that's another one that we use to screen people, but sometimes they're very good at hiding it. I did have a mom one time that went to the emergency room and was admitted for severe depression, and I could not believe it. In this instance, the mother had taken the screener and no flags were raised that depression was a concern. And so, use of the screener is kind of this like evidence-based practice that's used, but in the interviews, it came up with this concept of practice-based evidence, which is a complement to the evidence-based practice. In practice-based evidence, it kind of speaks to these relationships and interactions that exist before baby arrives. It's about those existing relationships with mom, and people with those relationships with mom have a good sense of who's struggling with postpartum mental health issues because they're in conversation, they're asking questions, they're observing. And so we heard many of you say, like, yeah, there's a screener, and then there's this other thing that we pay attention to. Like there's this quote at the bottom, but the type of things that I'll notice, I'll just have a feeling or I'll see certain signs. Like I said, you can just really tell in the way that they carry themselves and the way that they relate to their body or their baby. And so some of the cues that were mentioned that you might notice that there's mental health concern in the postpartum period are things like having a flat affect, not following through with commitments, letting personal hygiene and house care slip, exhibiting physical symptoms like weight loss, not connecting with their baby, or having emotional responses like anger or tearfulness. And so these are some of the other cues. This is like kind of the art of home visiting or art of working with moms in this period, that came out of these interviews and noticing some of these cues that come from moms.
So one of the things that we talked with home visitors about were the causes and consequences of postpartum depression and anxiety.
We might have some.
I'm sorry, am I coming through?
Yeah, I can hear you.
Okay, it might be my internet then. Yes.
Okay, I wasn't sure. All right. So we have this quote. Well, I think for Black and Brown people, or for Indigenous women at least, there are social implications because our hierarchy and needs is community driven versus individually driven. So when we're not feeling our best or able to smile and tell jokes or hang in places that we did before, that tends to add to that depression. So some of the causes that were identified were biophysical, cultural, social, as well as individual. And most consultants thought that postpartum depression was caused by a combination of factors, that there were many layers to postpartum depression or anxiety. Some of the causes given for biophysical were pre-existing depression and or anxiety, especially, fluctuations in hormones after birth, poor sleep and diet, as well as chemical imbalance and stress. Some of the cultural causes were interruptions to passing of traditional or cultural knowledge surrounding pregnancy and childbirth. Social causes included lack of support from others, including community involvement, family support, practical help with the baby, and fear of reaching out for help, as well as having a traumatic birth experience. And some of the individual factors that were identified were change in identity, becoming a mother, unrealistic expectations, loss of friends, and mom's experience with childhood trauma or domestic violence, as well as stress due to financial worries or lack of resources. Some of the consequences that were identified were the impact on relationships, choices, future choices, self-esteem, as well as self-care, self-neglect. And people talked about how postpartum depression or anxiety often affected mom's ability to form bonds with the baby, but it also affected her ability to maintain relationships with the other children or her partner, and could often lead to self-isolation. It also impacted future choices, like the decision to work or attend or enroll in school or have future children. And it lowered self-esteem, could lead to feelings of failure and shame and guilt for not bonding with the baby, or feelings of being lost. Ultimately, it could affect her ability to seek help or keep regular appointments, and could eventually maybe lead to self-harm or even suicide. So we also asked everybody about postpartum mental health and its connection to historical trauma. And we got a lot of interesting information. And a lot of visitors talked about how historical trauma interrupted transfer of traditional knowledge around birth. And one thing that we do know is that traditional knowledge seems to be protective of mental health. Also, hormones can trigger memories, and women are more vulnerable to fluctuations in hormones. And disruption to the community. There were a lack of examples of healthy breastfeeding, parenting, and healthy foods. But also, there was a fear of reaching out for help due to the threat of child removal. So we asked about services and interventions available to support postpartum mental health. And what we discovered is there is no universal standard of care or a set of services to address postpartum mental health concerns. Rather, services and interventions are provided based on the circumstances, context, and concerns of each person. What we did discover was attitudes towards services were favorable when trust with providers is well established and maintained. Postpartum mental health is covered well throughout prenatal care, and support group settings are available. Attitudes towards services were unfavorable when there was past bad experiences that shaped understanding of services, or past services did not help. There continues to be implicit bias on the part of providers. A lack of family support or stigma continues, including embarrassment with being seen at behavioral health. General mental health services and interventions in a particular community ranges from a few options to many. So most people we talked to talked about, for the most part, clients were referred to a primary care physician or medication for, or primary care physician for medication, or a therapist for therapy. Sometimes clients would end up in private practice. And in some like urban communities, there are these like bubbles of care, like Mom's Bloom in Kent County and Covenant Community Care in Metro Detroit. Some of the cultural interventions that were mentioned were getting involved in traditional crafts, like making cradle boards or moss bags, parenting support groups especially, community involvement, conversations with elders and sweats, and traditional practices such as cedar baths, fasting, traditional food, and smudging. For the tribe, as far as like the services offered in tribal interventions, traditional healers in behavioral health, but they may or may not have offered culturally tailored care. Also, alternative medicine was available in some areas, like aromatherapy, acupuncture, massage, light music, and water therapy. But ultimately, there was a lot of support from workers, especially like breastfeeding support and emotional support. There are some challenges to accessing and using mental health services. Many mental health services or cultural services are not tailored to address postpartum mental health. This quote kind of sums that up. I mean, there are all of our therapists at our site are able to use traditional medicines and traditional practices. Most of them aren't especially trained in postpartum mental health, but I think it's still worth it for families to see them. Getting connected to care is contingent in having a provider that knows the options in the community. Other than our behavioral health counseling here, I'm not really familiar with anything. Following up with your doctor to see about getting on a medication or another referral somewhere, but that's it. I don't know of anything else. Silos of care that contribute to lack of continuity in care. Well, we already have the problem of we're in two different locations. So there's a lot of problems with communication. And then I don't know if other organizations probably talk about this all the time, but we're always talking about silos, how we're in our own individual silos. And so that makes it difficult.
Great. And so then that led us to conversations around like, well, what would ideal postpartum mental health care look like? And so we had some folks say something like that sense of community is a matrix of everybody. The mother and the baby are floating in the middle there with help, and she's got every support and resource she needs. So it would be like a network of other like-minded women, Indigenous or not Indigenous, that would kind of go back to the traditional ways. Really coming into the woman's home, obviously invited, coming into the woman's home, providing them a soup, tea, maybe singing for them if that's something they'd enjoy, playing with their other children, taking some of the responsibilities, doing their laundry, doing their dishes, sweeping their floor, opening their windows, taking their dogs for a walk, checking in with them and kind of just sitting with them and being with them in a way that it's helpful, but it's not clinical and procedural. So this kind of led to conversations and too around like what would decolonization then of postpartum mental health services look like? And so part of then came out of that was like this independence from biomedical sort of dominance. I guess this is like getting at this idea of being less procedural, less clinical, but also bringing in the idea of reparations or reconciliation and return of resources to Native people. Then reconnection to land-based culture, so the restorative powers that nature and land have. Mentioned again was this idea of the nonlinear community matrix and just how like there's the community can be a source of healing and restoration too. Integration of life cycle teachings throughout a perinatal period, but also into services. And then thinking about this humble balance between sort of autonomous individual, but also collective needs. And then the idea of indigenization came up too, in terms of what would the process of decolonizing these services look like. So more like specific examples then came around integration across services. So having integration and sort of continuity of postpartum care. So that's like and including a seamless integration of traditional medicine and ways of life into that care, which also includes integration of balance, sort of the mind, body, spirit, heart, and considering all these pieces. Then also fuller integration of postpartum mental health services, knowledge, and expectations into the prenatal care, but also having flexible and inclusive community-based child, self, and family care available. Connection to other women and families throughout the postpartum period, and then more practically, just less talking and more practical support. Then there were some practical improvements to services that were mentioned, things like a broader array of home visitor services to include counseling, traditional healing, and others. And so this isn't to say that home visitors need to be doing these things, just that the home visiting model is so useful and could be expanded to include other types of services. But that also there could be drop-in services in a community. Community-based prenatal care classes to help build that community. Specific postpartum mental health specialists and maybe a curriculum around that, birth and postpartum doula support, because those services are available, but sometimes are a little out of maybe a price range or maybe not available locally. And then assessment of preferences on the types of services that women or families might want to use before it even comes to the time of needing those services. And then there was discussion about like some structural changes that might need to happen. And so that include like one, solving insurance issues. So as you might be familiar in using tribal health or Indian health services and then Medicaid and then maybe private insurance and being uninsured and all of these things that make the sort of a mosaic of care available. And so solving that would be useful, but also having like a well-established and integrated care safety in the medical setting. And so this is sort of thought of as, or I think was in reference to having providers that are just understand concerns and health and approaches to the perinatal period that are important to Indigenous women. That the needs of Indigenous women are met appropriately and with flexibility, but that we also have a better understanding of appropriate service development, a better understanding, of what appropriate service development might look like during that postpartum period, and then better identification and outreach to expecting Indigenous people in the community. And so then there were also impacts that the COVID-19 pandemic have had. And so this is what we've heard people say. So first, here's this quote. So we currently service in behavioral health approximately 400 to 450 individuals, most recently an increase of 40% or more due to COVID. Our crisis calls right now are just astronomical. Even though we're a good year and a couple months into this, I'm averaging approximately 3 to 4 crisis calls a week. So it's been troublesome. We deal a lot with trauma. There's been a lot of depression, anxiety, and trauma coming out most recently due to COVID and loss of positions. And actually, this is a really great opportunity to speak with you because the increase in women and even young ladies, youth, and children, I mean, we're finding a lot of suicidality behaviors and so forth. And so COVID has had impacts on individuals and families. And here's this quote saying, COVID has exponentially affected birth in every way, shape, and form. So for example, people are making decisions in birth and birthing decisions out of fear of infection. So there's been an increase in home birth and doula requests, but also especially in the early times of the pandemic, there's been some separation of moms and babies due to suspected COVID infection. We also have like fear of infection in the home and then limiting visitors into the home, which has increased isolation, but also increased time for bonding with the baby. And there's just generally more awareness of mental health states with the pandemic. There's also fear of child infection, which limits activities outside of the home, some increased anxiety and mental health issues among children and parents, and also some discussion of potential developmental delays among children due to their limited outside interactions. There's also been impacts on service provision that have come from the pandemic. For example, less frequent in-person contact throughout pregnancy, meaning home visitors or others know less about what's going on with a family, kind of fewer eyes on the ground. Also, virtual interactions are shorter because people hit their attention limit a little sooner than they do in person. Families come in and out of programming due to COVID-related stresses and disruptions to schedules. And there are staff changes, including losing and gaining personnel, which impacts consistency in services available. But then there's also these logistical challenges that have come up. Being out of the office means that communication between departments and staff isn't happening like it maybe would when we were in person more often. Intake paperwork and assessments are challenging to do virtually. And the switch to telehealth is challenging for many due to connectivity issues, lack of privacy, increased disruptions, and also some unclear social rules and norms about using Zoom. And then online communication has provided a way for some families to maybe disengage in services. But there's some creative solutions that have been implemented, including incentives like entering a drawing that might encourage participation. Some have scheduled virtual play dates as a way to encourage community. Some folks are using social media and texting a lot more than maybe they would have before the pandemic. And there's just a general sense of being flexible and understanding and trying to meet families where they are right now. And so kind of to end up then, we're thinking about to address the postpartum mental health concerns among Michigan's Indigenous women. There's some next steps that we might take, including trying to connect with others doing similar work. What are other areas doing to address these concerns? Could we launch a more in-depth study of postpartum mental health and hold conversations around what are community-based solutions that might be able to be implemented to address some of the things that are brought up in these interviews? So Jimmy Gwetch, so thank you very much for your time here. And I think we can maybe turn it over for a few moments for questions you have, thoughts or concerns, anything you'd like to share.
We did some surveys in December with everyone here, and mental health and depression with in pregnancy and after birth were listed for mothers, were listed as one of the top 5 priorities. So this was super timely. I really appreciate it. And I look forward to seeing the bigger, I'd like to nerd out on the bigger PowerPoint.
Yeah,
So
for
thank
sure.
you.
Yeah. Yeah. Have you guys thought it, like had conversation? I'm just curious about like what to do about that then. It's a big question with no clear answer is my thought, but
It is a big question with no clear answer. So I was really glad to see that you guys were already on this. Seems like there's a lot of information out there. One of the things that I've read is that substance use was identified as possibly a reaction to, but substance use seems really closely tied to postpartum depression.
Mhm.
And I wondered if that came up at all.
Yeah, great question. It did. We actually specifically asked about that. So we made it come up, I think, as a topic. But yeah, that's one of the pieces that's like in the like bigger PowerPoint kind of thing. But yeah, it definitely did come up as like a response. Yeah, it's really complicated, you know. In some instances, though, this period of like pregnancy was a time where there was a step back from substance use. So that sober period that comes with pregnancy was a thing that was mentioned. But yeah, the kind of link between, you know, early life trauma, historical trauma, substance use that might be related to that, and then the postpartum and the COVID and all of that kind of, yeah, creating quite a milieu, maybe a messy soup of of mental health concerns. Yeah. So it definitely did come up.